So thanks for coming, everybody. We said we'd spend an hour. We're 3 minutes in, so I'll kick it off. I think most of you know me. I'm Mike. I'm just here to introduce Hans. Hans's bio is on the Syngap research website. He's an MD. He's a Master in Medical Sciences from MIT. I don't know what that even means. But his MD is in infectious disease. He has a Syngap child. And if you read our blog diligently, which I'm sure you all do, you will know that he's been hard at work on everything from ICD-10 codes to other things. So Hans very graciously offered to just speak to us and share his perspective as an infectious disease doctor and a Syngap parent. A few people have shared questions in advance, which he will speak to, I hope. And just an FYI, this is being recorded. If that makes you uncomfortable, I'm sorry. Just stay on mute. But if you come off mute, know that it's being recorded for posterity. So with that, sorry for the brief introduction, Hans. I'm sure I could have said more, but let me hand it over to you.
Yeah, and what I would say is, you know, it's a small group, so if you need to interrupt me if I've said something that doesn't make sense or needs to be clarified, just please feel free. So let me just start by saying that, you know, we do have cases here that I've taken care of, and I can't go into great detail because of privacy concerns and you know, a pretty stern warning from my hospital. I'll express some personal outrage about COVID, but I feel like everybody wants immediately to hear about Syngap. And I don't think of my child, and our kids are different, big, small ways, pretty broad spectrum, but I don't think of my little guy, Eric, as having an immune deficiency, making him at, you know, dramatically increased risk of a bad outcome. So just as background, an immune deficiency to me is someone whose system has difficulty generating, let's say, antibodies, or their cells, which engulf bacteria, can't kill the bacteria once they're inside the cell. There are certain conditions where they just don't generate those free oxygen radicals to kill bacteria. They do it half as good to a tenth as good, 1/100th, and they're all then, you know, pretty severe. So with my little guy, I'm not particularly alarmed should he be exposed to coronavirus. I say to myself that it's likely to be a run-of-the-mill cold, if anything. You know, I think if he were older, my worries are that, you know, as they age, are they more at risk of aspiration or the poor coordination that happens up here that keeps their airway clean, clear, coughing up stuff. If you recall from Ingrid Scheffer's last Camp 2019 article, there was sort of the first report of a Syngap passing away and undergoing an autopsy, and the circumstances where they had an aspiration pneumonia that was severe. So, you know, our kids, for lack of a better word, are poorly coordinated, you know, whether it's, you know, forming memories or even just the coordination of walking, fine motor, controlling their, you know, 1,000 maneuvers to create speech. It can lead itself also to getting food, liquid down the wrong pipe. And if you can picture in the life arc, you got to be careful with your babies getting, you know, food or water down the wrong pipe, and then also at the extremes when they're older. So I'm not worried about the typical Syngap. It doesn't have a huge effect on the immune system that we're aware of. And I haven't seen, beyond just the routine, you know, colds and ear infections, a problem with my own kid. So just to sort of get to that right away and set it aside if it's at the tip of someone's tongue. What I'd like to, yeah, Rebecca, go for it.
So one question I have, like one thing with Autumn, she doesn't have the ability to cough productively. So we're always concerned when she has a respiratory infection because no matter how much we try, unless we get her laughing, there's no production. And so obviously when there's a concern over something that is purely respiratory, it's what is that impact on her? Can you speak to that at all?
I can try. And what I can say is it's not what we would call purulent. It doesn't make a lot of pus, and the cough is largely dry. So I don't know if that's reassuring, but there isn't a lot to even bring up. It's more just the inflammation in the lungs that, you know, people experience.
So is that the case when it turns into like ARDS?
So ARDS is more of a dysfunction that the little sacs where the membrane is so thin at the very ends, they allow oxygen to go from one side to the other and into the bloodstream. That membrane gets thicker, so oxygen can't get across as well. So it's not so much pus or, you know, stuff that they can't bring up. It's really a defect at the membrane where oxygen exchange occurs. So that it's a condition that's been associated with other events, smoke inhalation, drowning. It's when the lungs really take a terrible insult and then, to a degree, I don't want to say overreact, but really have a brisk reaction. You know, when I think of coronavirus and COVID patients with ARDS, I'm picturing, you know, the person who's already on 2 liters of oxygen because of an underlying lung disease, not necessarily, you know, a kid, a young adult, a healthy adult, unless there is some unique genetic aspect that goes out of whack. And I wouldn't expect that in a Syngapian.
Thank you.
Yeah, sure. So what I was going to say also is, and this is more of a personal thing that I feel like I enjoy getting off my chest. I've never felt more let down by government in my entire 46 years of life. I mean, it's really abysmal. And I'm not talking about the response right now, but you know, when we were talking about it as doctors a couple of weeks ago, a month ago, I said to myself, you know, where were the scientists, you know, keeping an eye, going out, finding these viruses, getting us prepared? And they in fact did. I mean, the fact is that SARS was 2002, 2003. MERS, the Middle Eastern Respiratory Syndrome, was 2012. And in 2013, the scientists found a SARS-like virus in bats in China. And we're like, hey, we found something, you know, we should keep an eye on it. We need to study it in greater detail. And then 5 years ago, they actually published something in Nature Genetics. And I want to read it verbatim because it just can't, I think, otherwise convey SARS-like cluster of circulating bat coronavirus pose threat for human emergence. And I don't know specifically who gets paid to worry about pandemic preparation and the threats that can come at us the way they did from SARS and MERS, but that person needs to be fired. Even if you go to YouTube and you punch it in, Bill Gates gave a talk 4 or 5 years ago, a TED Talk, on what scares him, and it was a pandemic. And I just can't imagine that there isn't some fallout in some way for such a just terrible job, so terrible job. So viruses make a jump periodically from one species to another. And, you know, SARS, we presume from bats, MERS also bats, and maybe an intermediate And then a big example that's potentially the easiest for me because of my background is HIV. Having made the leap from monkeys, various types of monkeys, to humans. In the monkey, it's been called SIV or simian immunodeficiency virus. And you can see what happens in an adult in the sense that that virus takes on a life of its own, sort of smoldering along. In this case, the infection is much more brisk and it's also very contagious. So we've seen, you know, I think we're close to hitting the 400,000 mark. And we talk about contagiousness and the R naught value of 2.6. Mortality is tougher to judge, but it may be under 1% when you factor in all the people that are asymptomatic and have mild symptoms. That's the bulk. That's 80%. But then, you know, 5% are going to be in an intensive care unit, which typically implies that they're on a ventilator. And for those that are 80 and above, you're looking at mortality rates of 15%. 70 and above, maybe it's 7 to 8%. But I see plenty of people actually doing fine or needing a little bit of oxygen support and pulling through. Typically, it's how fit you are in the sense of smokers, people with underlying, you know, heart disease, lung disease, they're not going to do as well. So for the vast majority of us, it's just a matter of cold-like symptoms, cough, fever, aches, a viral syndrome, and wind up getting through.
Hans, I'm sorry to interrupt you again, but
perfect timing.
I've seen some conflicting reports about the impact on people with neurological conditions, especially considering the increase or not on epilepsy. Can you speak to that at all?
I don't know that there's anything unique to this virus necessarily that makes it worse, but rather the same thing that may happen with, let's say, fever syndromes. You know what I mean? A kid who's got fevers going on in the background, exhausted, lowers their seizure threshold, and maybe gets worse because of that. As far as we know, this is strictly, you know, sort of from the nose down to the lungs. There's no virus that's been detectable in blood. So we don't worry about it necessarily spreading through the bloodstream. There are, you know, cases of what we would call a change in mental status, in the sense that it can tip a person who's fragile out of balance and throw off their mental status. So to me, at least in my experience, that's been the elderly. But that settles down and they wind up getting sort of reoriented and back to their baseline.
So Hans, if I'm hearing you correctly, you're saying there's nothing specific to Corona and Syngap that we should worry about. But then as parents of fragile kids, generally, whether you want to call them medically complex or medically fragile,
yep.
Do you mind just, I know you had a few questions that were emailed ahead, but before we get to those, do you mind just sort of giving the 101 for anyone who's unclear, like how should we as parents be thinking about our kids when we see symptoms that give us pause? And then I think and then sort of a side question to that is, the few times Tony has had the flu or other diseases or other infections, he's gone down pretty hard. And our neurologist has just said to people, well, sometimes these kids with these rare diseases tend to present differently. And that's a broad truth and not specific to coronavirus. But I've always kept that in mind when I've been talking to people. I don't know if you have any thoughts on that, but if you wouldn't mind covering
that's
those
just
things.
You know, literally the spectrum for our kids is so wide that I don't want to come across as being able to know exactly for each kid how it's going to play out. I mean, the fact is, you know, I see pictures of Syngap kids in wheelchairs or using, you know, sort of like the rolling walker to get around. And my kid's motor function is a little bit better than that. But other kids have to worry about swallow and feeding issues and so forth. So to me, it deals a lot with the airway. I'm not so much worried about the fundamental units of the immune system, the white blood cells, the T cells and B cells. Those should have function that would be expected to be normal and fit. But, you know, if a kid is on a medication that slows down immune cells, okay, you know, that's a different story. But fundamentally, I don't think of Syngap as being a problem for the immune system. As Rebecca was speaking about, you know, if a kid doesn't have that muscular control to really do a deep cough and bring stuff up, I would particularly be worried about what we call our secondary infections. So you deal with the flu, but that damages your lungs enough that another pneumonia can move in. And we do see secondary infections with coronavirus. So for example, that has a course where person gets sick and they've got a runny nose and they're coughing, but mild fever and everything's okay, and maybe sleeping and a bit more, and they're clingy, and then they're getting better, and then they get worse again. And then the fevers come back and they're maybe looking worse than they did the first time around. So they've cleared that first infection, but it's left them vulnerable for a secondary pneumonia. So that's something that, you know, is well described, and I could easily see happening after, you know, an insult to the lungs like coronavirus.
How do you gauge the difference in that? So I think what I've seen is that basically around day 8 of infection with, sorry for my children in the background, day 8 of infection, you basically turn, and it's at that point that it either becomes serious or critical, or you start to get better. So how do you differentiate that turn from a secondary infection?
Typically, to me at least, a secondary infection is going to have changes such as the fever getting worse. I mean, what we see in patients with coronavirus getting worse, it's usually their oxygen requirement, because the ARDS component is kicking in. So a change in the sputum production, a change in their fever, those are two things that I would look for. The rest of it, unfortunately, is all based on hospital testing. You know what I mean? So I can talk about white blood cell counts changing and x-rays changing, but that doesn't help a person at home. But as far as I'm concerned, I mean, you hear about, you know, a 14-year-old in China dying. That's potentially one out of how many 100,000, let's say, that got infected or more. So it's really something, I don't want to say predatory, but you know, hitting a weak spot in the infirm, and I think more of the elderly in that case. I don't know how medically complex all our kids are, but if they do have trouble with their lungs at baseline, that would, you know, leave me to be a bit more concerned and on my toes.
Cool. Do you want to go to those 4 questions, Hans?
I can try, absolutely.
You want to read it?
Hans, sorry, it is Jessica here. I just had another question.
Please.
So here in New York, there's a lot of discussion about asymptomatic presentation and mild presentations.
Yep.
But there's not really too much detail about what that looks like, because those people generally do not qualify for being tested.
Yep.
So what does the spectrum look like from asymptomatic through to moderate symptomatic?
Well, so literally asymptomatic is no symptoms whatsoever. It's a person who's going to work, whistling, and life is fine. They just don't even notice that they have a coronavirus infection. There's no, what we're talking about, the easiest way for me to explain it is just sort of marching down from the nose all the way to pneumonia, right? So you've maybe heard of people having a change in their sense of smell.
Yes.
Yeah. Okay.
Smell or taste disappears.
Right.
It's said to be one of the early warning signs.
Yeah, and taste is very much informed by smell. So to me, at least, it's you know, here's step one, and then sore throat. Okay, so runny nose, change in smell, congestion, sore throat, and now we're getting to a location where laryngitis, what would you call tracheitis, the trachea being involved. So there's a cough, and then bronchi, and then pneumonia. And really, once you get down to here, it's cough and shortness of breath that are going to be the typical complaint. So a mild infection is just that person who's, you know, using their tissues, sneezing, maybe a little bit of coughing, has a sore throat, but is not short of breath. They're not going to the emergency room or thinking about it. Oh, I've just got a cold, I'll get through it. So, you know, unfortunately, we don't have a great hold because of the lack of testing. And they can trumpet all they want. Sorry for the pun, but there hasn't been the same intensity of testing as there has been in, like, the poster, you know, child of testing has been South Korea, where they were very aggressive and seem to have, you know, really brought it under control. All these countries have incredibly unique circumstances. So I really hesitate from using a broad brush. If you keep in mind that South Korea had most of a sort of outbreak in that church in Daegu, or if I'm mispronouncing that, I'm sorry, but they had to sort of hone in and deal with contact tracing there. You know, China, Italy, Japan, it's all very unique. And now the United States sort of led with the Seattle area and then New York, and you see these hotspots all over the place. But 80% are going to be asymptomatic or mild, and they're pretty tough to, you know, get your hands around.
And for an asymptomatic or for a mild presentation, how long would that be expected to run? A week, 2 weeks?
No, I would say less than a week.
Less than a week, okay.
Yeah, I mean, there's always going to be quirks, but, you know, the incubation period, typically 2 to 7 days, average of 4, maybe 5. So there's always going to be that bell curve, but the majority of people are just sick for a few days and then they're over it.
Thank you.
Oh, sure. So that first question is, my son is currently hospitalized for a medication shutdown and stabilization in a special unit for autistic adults. Is he safer over there or in his special home where he was isolated? And I would like to believe that the hospital setting is safer, in the sense that I hope it's of a high quality, good reputation, you know, people who are very compulsive about their job sort of achievement and performance. Because in that case, you know, everybody's meticulous about hand hygiene. If they've got symptoms, boom, next thing you know, they're calling employee health, they're able to be tested, or they're just furloughed and, you know, tested, told to come back when their test is negative, or just told you've got a week off, we'll see you then. Whereas, you know, at the home, people are coming and going. Maybe it's on lockdown, but there's still, you know, assistants, let's say, who have to come and go. And it's, in either location, unpredictable. But I would like to believe that the hospital setting is just a smidge safer. It's tough to know for sure. So I hesitate to be dogmatic with answers that are, you know, trickier. On the one hand, Ingrid Sheffer stated that our kids are, and this might be a misspelling, but normier at risk than normal people. On the other hand, the Angelman community considers their patients to be one of the risk groups, and the first coronavirus death in the Angelman community has been reported. Why are there these differences? And I think it goes back to the uniqueness of the patient, in the sense that that spectrum where I might feel, I don't want to seem cavalier or confident or overly confident, but what I've seen, my little guy handles viral infections fairly well, respiratory ones. He's had multiple ones. I mean, you know, the typical household, you know, November through April, it's a revolving door, but literally confirmed influenza A maybe a month ago, 6 weeks ago, and then RSV and influenza B on the same sort of testing. Last week when he had a fever and a runny nose, it was rhinovirus. So clearly they get sick pretty easily, like any kid in, you know, preschool, school, but he handles it well. If I were dealing with a child that had more of that difficulty for swallowing dysfunction, maybe already had RSV as a 1-year-old and has bronchiectasis, that's a structural lung change from early infections in life, that's a different, unique circumstance. So I don't know this Angelman case that passed away. Were they older? Were they frail from a pulmonary standpoint? I don't know that Angelman's syndrome has any unique immune deficiency to it. And again, going back to my statement of if the body can make antibodies in the right amounts with the right shapes, if the cells can coordinate that, if the cells can gobble up bacteria and kill them efficiently, I don't think of them as being immune deficient. But you know, they live in a household with a smoker, so they see secondhand smoke. They had those infections early in life. They're actually, you know, a 32-year-old, a 40, 50-year-old, whatever it might be. There's usually the details matter a lot. So again, we can talk about individual kiddos, and I can give you a sense, but I'm hesitant to seem like I've got a crystal ball in that regard, but hopefully you get the broad strokes. Are our kids at higher risk of contracting COVID-19? And if contracted, how will their response differ from other kids? You know, right now, at least it's your level of, you know, networking and social interaction, what you're going out to do, and what's going on in your local community. So, you know, I'm sorry to say, Jess, right, living in New York City right now, all you want to do is eat out of the freezer and not leave the house, right? Some of that is potentially overblown, I understand, just out of a personal vendetta, maybe, towards New York City. But considering what's going on in New York, just the raw numbers, it's an outbreak in full throw, and I wouldn't be out on the streets. I would just, you know, make an excuse to stay home. If our kids contract it, what will be different? I don't know that there will be a big difference. Maybe if, you know, their fevers are high, there will be, you know, seizure breakthrough and a lower seizure threshold. There's been, you know, chit chat among the autistic community for quite some time that fevers made their kids better, that they acted, I don't know, more lucid or more interactive. There has been, I want to say in the past 3 months, a Science or Nature paper on this phenomena. And I have to admit, it's really challenging science, in the sense that it seemed as if the immune response modulated Th17 immune cells in such a way that there was an improvement in function. You wind up getting into the hardcore science and neuroscience, and it's a real challenge unless you do it full time. So we do know that some autistic phenotypes improve with fever. Tough to grasp. I don't think of my little guy as being particularly autistic. And I think that there's some incredible complexity to that label and the brain, obviously. So it's a real challenge, and I struggle to find anything that's going to be uniquely different for a Syngapian, other than how you've seen your kids behave with other viral infections. And I think that's the key to sort of come back to. I don't know that there's anything dramatically unique to this, except for the elderly getting, and the infirm getting real sick. That does happen with other viral illnesses. So if people have heard of RSV, respiratory syncytial virus, for the longest time, we just worried about it in kids and bronchiolitis in January and February. But it's clearly a problem for the elderly and has been a noticeable means to their exit. So there are plenty of viruses that cause trouble, but if your kids have been dealing with them fairly well, I'd like to believe that they'll do fairly well if they come across a COVID. If your kids do struggle, for whatever reason, their upper airways become bogged down, or they just struggle under those circumstances, you will need to be on your toes more than others might be.
And Hans, hi, it's Virginie. Just anecdotal, that's something that we have noticed in Ty. He does not have the autism diagnosis, and he's not considered autistic. But since he was an infant, after having a fever, we noticed a lot of progress right after. It's like a reset of his brain. And when talking to his neurologist about that, she did confirm that she is seeing that more and more, and that there needed to be more studies on this. So just anecdotal that we are in that category where we see that. Same with after he has a big seizure, we usually see a big increase of skills afterwards. So just to go back to your point that we are noticing it.
Yeah, there's a huge spectrum to our kids. I mean, really huge. And Virginie, I can get you that paper if you have, interest in a deeper dive in that subject, because it was of such high quality that it made it into, one of the top 2 journals in the world. And it was crackerjack science. It's just deep. It's just really, really deep.
Okay. Not sure I'll understand everything, but I would love to take a shot at it.
Just remind me if I forget. Interested in mutating strains, if long-term immunity is developed, what signs should we look for in our nonverbal Syngapian? So this is really 2 questions. And the second one, in terms of signs, I feel like I've touched upon that in terms of what to expect. Hopefully, that if your kids have handled viral infections fairly well, they'll handle this one as also. And then for immunity, and it branches out, the idea being that, you had, chickenpox as a kid and you don't have chickenpox again. You do wind up having shingles later in life when your immunity wanes. So with immunity, ideally, you're set for life, okay? We believe that's the way it is for hepatitis A. Have it, clear it, don't get affected ever again. We don't obviously have the experience here. The original SARS sort of burned out and people were sequestered, and we haven't seen it come back. As far as I know, it didn't go through any seasonal component. It was just a matter of people traveling and exposing, inexperienced, unexposed people and causing new outbreaks where they landed. I was worried about immunity and that it could be short term, and this would really turn into the worst sort of Hollywood movie you could imagine on contagion and pandemic. What I was very happy to see, and it happened maybe 3-4 days ago now, is that the Chinese numbers went down to essentially zero. And, you know, can you believe the numbers? Whatever. But to at least think that there was no more local transmission going on was incredibly reassuring, because the fear was, and in fact, you know, there were case reports and some degree of what was called relapse, that people were coming back and positive again after they had been negative on tests. And the scenario or the case that comes to mind is a young Japanese woman who, I believe it was in late January, was discharged from the hospital, and that usually meant 2 negative tests before they would let you out of the hospital. Excuse me. And about 3 weeks later, she came back complaining of sore throat, some low-grade temps, and they tested her and she was positive again. And, you know, if a person doesn't have immunity for, you know, at least a month, I mean, here she is back after 3 weeks, that's scary to consider. At least they felt at the time, and it seems to be the explanation, that maybe the tests weren't done correctly, they weren't sensitive enough, they couldn't, you know, necessarily consider them accurate. And then also, it's not uncommon that we have a bit of a tug of war going on between the immune system and a virus. So if you can imagine, you know, getting infected and it making its way down, the body starts to clear and sort of push its way back up. But, you know, the virus gets another toehold, something happens in between, something else distracts the immune system, for lack of a better phrase, and it makes a short, brief comeback. I think that's likely what's happened in people that have had repeat positive tests after being negative. So seeing the Chinese numbers come down to zero was very reassuring, because I was afraid it was going to come down, but then come back up again, in the sense that despite all the measures that they took, people were getting reinfected, that there wasn't protection necessarily. We know that certain viral infections like the RSV I mentioned before, you can expose a person, and they did this 20 years ago, where they took adults that had an RSV infection, they took the exact same strain and exposed them to it at a month, 2 months, 6 months, 9 months, and half of them got infected again at 2 months. So, you know, we haven't had enough time. They have done a sort of re-exposure or challenge experiment in monkeys, and at 1 month, they didn't get reinfected. So hopefully there's a durable level of immunity, and it lasts, it creates herd immunity, and the infection essentially runs out of avenues to infect, and this just settles down. I may be naive, I may be optimistic. I want to believe that this will, you know, burn its way out or work its way through in the next 3 to 4 months. I know they've talked about August or even into the fall. I just don't want to believe it. Maybe that's it, but I think there's grounds to think it'll be a few months. There's no seasonal aspect that we know of to it. It had just as much contagiousness in Singapore as it did in Beijing and northern climates. So will it come back in the fall? I think people were drawing a parallel to the flu of 1918. And yes, it was a pandemic. Yes, it was a virus, but there's still apples and oranges. So So I want to be
Hey,
optimistic.
Hans.
Go for it.
I'm sorry. So I guess when I think about it from a viral perspective, I think about it in reference to the flu. And, every year we have different strains of the flu that they're trying to inoculate for. So why would this be necessarily different? Or do we just not have enough information to say that it is different?
We don't have enough information. And the immune response to the flu is going to be different than this coronavirus. That's a given. So.
Well, I guess I'm thinking about it in terms of, so I think the original as far as it mutating, right? And so we know it's already mutated once. And what the opportunity over 6 months is for it to mutate again and either become better or worse.
But mutations don't necessarily have any change or meaningful change to make something more infectious. So the antibodies that a person has could be protective regardless of what happens in the background in that virus.
But also the flu virus is a human virus. It's one we've had forever, whereas coronavirus jumped from another species, like it's novel, right? We haven't seen it before. But what we've seen so far is that it's not mutating as rapidly as the flu virus mutates. Is that roughly correct?
There's a lot to that verb, okay? So little like nucleic acid changes, they might be labeled as a mutation, but does it translate into something meaningful? Does it change the structure of that protein that suddenly an antibody can't neutralize it? So, you talk about this coronavirus having, a crown, right? The corona, the little studs that are on the outside. There can be a mutation in that protein, but it doesn't necessarily mean that the antibody, let's say binding that, won't work.
Sure.
We'll see.
So we've got 15 minutes left. I want to make sure that if this great content so far has triggered any questions, people get to talk. And I just want to ask, because these are all too rare, getting Syngap parents together in real time online. I just want to ask that if people talk, you just say who you are, where you are, and a little bit about your kids. So for instance, Mike, Northern California, Tony is 6. Hans, where are you?
Yeah, Hans, Western Massachusetts. Eric is 5.
Rebecca.
Sorry, Rebecca, Southern Pennsylvania, Autumn is 11.
Cool. We can just go around and everybody can intro themselves, but if people have questions, feel free to jump in.
Hey, I'm Erica, Center, Alabama, and Claire Beth is 10. And I do have a question as far as here, it is very hard, if at all, to be able to be tested because there actually were no tests in our area for a while until today. We just have one positive test. So we're assuming there was 10 at a local pediatrician's office and a urgent care type facility. So with that being said, if our child comes down and we feel like, Claire Beth says hi, we feel like we also have another child who is medically fragile as far as she has severe severe asthma. Can we request to be tested, or is anybody seeing that? Because a lot of parents are being turned away even if the kid tests negative for the flu and they still have an upper respiratory, they're telling them just go home and stay home for 14 days. I would rather know myself so that we could either keep her away from our other child or be on the lookout for something. But is anybody seeing this same thing in their area, or is it just us here in the deep South?
No, I mean, it's the same thing here for the hospital system I work for. We're only testing people if they're going to be admitted to the hospital. So if a person, even has all the all the symptoms, they were exposed to someone, but they look good, they're eating, drinking, breathing off oxygen well enough, they're going to go home without a test.
Okay. And I mean, is that not hurting our numbers? Like, as far as
Oh, absolutely. I mean, epidemiologically speaking, you know, we'll never have a grasp of how many people got infected. Yeah.
Yeah,
Okay.
this is Aaron, San Diego, Sons Jackson 14. So if I could just add, Erica, that to what Hans is saying is, yeah, I think admitted patients. So again, I work in a healthcare system and I'm dealing with the testing into this every single day for about 12 hours a day, sometimes 14. So right now, the most, like as Hans said, is the admitted patients. But then also honestly, the next most vulnerable patients are the first line caregivers. So the physicians and the nurses are wildly susceptible. And so we are terribly concerned given their continued interaction with the patient population. And then again, because we can't adhere to the stay at home being essential personnel, we end up running a risk of contaminating our family, who then, it just kind of snowballs. So again, this is a challenge. And again, we are working and slowly building capacity. The manufacturing side is working hard. So there is a lot going on. And this is not a simple test. So most people think, oh, you just kind of run a blood test. This is a very complex test that's PCR based. So we're looking at RNA analysis, which is a very time-intensive sort of procedure in order to get it to a result. And so everybody's working very hard to bring these systems into place based on the instrumentation and the reagents. We likely won't see an IgG, an antibody type of test for some time that has any reliability, which would give us some idea of what the historical sort of exposure presentation has been across the general population.
So the old corona test, like the ELISA SNAP test, like that type of thing, is not capable to pick any of this stuff up. Okay.
No, you'll hear there's a rapid test, but it's an antibody test, and these are not for acute. So like Hans is concerned about acute infections, and that's what we're sort of talking about. And
Okay.
so, that's where everything is focused on, is the acute infection state.
So
when you
like
say-
if we got
I
tested,
think we've seen some conflicting data on, at least I have, on the effect on the population, that at least 25 to 40% of the critical cases are actually younger people who were quote unquote healthy. So, I mean, is the assumption that they just have an underlying condition that we weren't aware of, or is it truly not just a concern for the elderly, but everybody?
I mean, I'd like to see the details. I've become so skeptical that to me, it's propaganda until you publish it. The people who are in control are old men, and, they want to make everybody think they've got to be shut in to save, everybody else's life. And there's a reason, for that, and it's justified. But I don't believe half of what I read anymore, or what I hear.
Hans,
Yeah.
hi. This is Olga in Houston. Drew is 12, and when he was younger, he would get sick all the time, but he recovered, and of course, it would increase his seizure activity. He had a lot of croup as a young kid. Does that do any damage to the lungs, or does that make him more susceptible?
No, I don't believe so.
Oh, okay, not. And two other quick questions. I know we have one kiddo overseas that's being tube fed and in a wheelchair. I'm just wondering, being tube fed, does that make it a whole other, because the lung, she's not using her esophagus? And
Yeah, I mean, that's clearly a kid who's
got,
got one hand tied behind their back when it comes to lung function and let's say coordination. I mean, you worry typically about chronic aspiration, the changes that can happen with chronic aspiration. So, you know, I would feel less confident as the parent of that child, but hopefully they'll do well.
Yes. Okay, great. And well, I have been reading conflicting information, and I heard your statement, and I certainly concur that it's hard to know what to believe and not to believe. But is the heat resistant? It's not supposed to be heat resistant, right? Or it is heat resistant. Is that correct? I mean, the different climates are not really.
Okay, I'm sorry. So when I heard heat resistant, I was thinking of, you know, what it
The
could
virus.
be.
I'm sorry, I'm going back to the virus.
Yeah, no.
Okay.
I was expecting, you know, there's environmental studies. How long does it last on, you know, stainless steel? How long does it last on copper, etc.? And I thought maybe you were alluding to if it's killed by the normal usual temperatures. But what I was getting at, and I think you're getting at, is there a higher risk, let's say, in a colder climate versus the tropics? And what people have just emphasized, and it really harkens back to, you know, the wishful thinking that April would roll in and it would just disappear. It'd be a miracle. And, you know, scientifically, it was just as contagious in Singapore, which is on the equator, as it was in northern latitude. So it's doesn't seem to have any difference whether it's, let's say, Houston and hot and humid, or Minnesota or New York right now, and up here.
Yeah, it was over 90 today, so I was just being optimistic.
Wow.
Yeah, already. Okay, thank you very much.
I see Rita's got her hand up too.
Hi, yes, this is Reetta. I'm calling from Montreal. I have a daughter, my Syngapian Ilona, she's 12. And I actually had a question. I don't know if we have time for a short individual question. Yeah, okay. She has been sick for a couple of days now, and we're quite isolated, but it's very easy to get tested in Montreal. You can just drive through a tent, basically. But she's been having fever, but in my opinion, it's a sinus infection, and I got her on amoxicillin since Monday. And I'm imagining she's a little bit better, but still pretty rough going. And I'm wondering, besides just keeping her on the amoxicillin and looking at respiratory problems, is there anything else I should do? Is it worth going out of the isolation for testing at this point? She has had a lot of respiratory problems in the past, but she's always come through. She does have aspiration problems, but not severe.
Yeah, you know, I also like the idea of knowing. It's one of those things where, and just as the personal example last week, you know, to have my son have his cold symptoms and, you know, a goopy nose and so forth, I wanted to know if we could blame something else. And A, I want to know for him. B, I want to know for me, so that I know for my patients. There are tests, a swab into the nose. It can be run against like 14 different pathogens, and you get an answer then. If your pediatrician can do that, or if you want to start with the COVID test and drive through, then you do get an answer. You know, in the COVID cases, we're trying to avoid antibiotics. And I think that's also, you know, a good thing as just a fundamental principle. Believe me, I have my sinus infections too, and I reach for my Augmentin. But if you can pin it on a virus, then you might be able to scale back on the amoxicillin and just use, you know, supportive care to get through.
All right, thank you.
Sure, good luck.
Hans, why do you try to avoid the antibiotics with COVID? I mean, obviously it's not a bacterial infection, but like, is that just because it would give us false sense of security?
Well, no, just sticking to, you know, the principle. If you're not treating a bacterial infection, you don't use an antibiotic.
Right.
Can you speak about the articles we've seen about not using ibuprofen?
Yeah, I think they're very messy. I mean, it's challenging to know what's happening, especially, and believe me, I just in recent time, so I stay as vague as possible. You know, the fact is, when you get a person into medical care and they're getting crushed with antibiotics because people don't know what's happening and they're worried, and they're getting around the clock Toradol injections, their kidney function goes haywire. They're not going to do as well. The next thing you know, they're on dialysis. So it's really messy to tease this out. And, you know, there are alternatives to NSAIDs. So, you know, a lot of times when my little guy winds up with his fever, viral syndrome, you know, we're alternating between Tylenol and ibuprofen and Tylenol and ibuprofen. Under these circumstances, I would just stick with the Tylenol and try to make the best of it. I would avoid them if I have a choice, but I don't think the data is, you know, something to it's not a slam dunk.
Hans, we got one more from someone from Neil who's on a phone, and he said, what about using UV light in the bedroom to kill things?
You know, I'm sorry, I don't have a good answer for that one. I mean, I see them at the hospital, but I don't know what their effectiveness is against viruses per se. They've always been, you know, sort of something alluded to for tuberculosis, but I don't know anything about a coronavirus and neutralizing them. It's less aerosol than, you know, we believe, in the sense that it's more of that droplet spread that we have to worry about. So a lot of times, you know, those UV lights, they're usually up close to the ceiling. They've got that little sort of visor in the way so that it's not raining down on you, causing skin cancer. So I haven't looked it up specifically, but I wouldn't use it. I'd be hesitant.
All right, we're on the hour. Does anyone else have questions?
I have one. This is Summer. Can everybody hear me?
Yep.
This summer, I'm in Montana and Riker is 8. I was a little late to the call, but when Riker was 3, between like 3 to 5, if he got a common cold, it basically put him in the hospital. He would get admitted. His O2s would drop to like 80. And so since then, they had prescribed him a nebulizer full time. So kind of, especially during the cold seasons. I mean, the kid constantly has a runny nose, clear majority of the time. I still have no idea why it's constantly runny. Would you recommend I continue the nebulizer, or does that benefit to kind of keep the lungs open through this process? I mean, we're pretty isolated right now, but is that beneficial?
I can't give a straight answer.
Okay.
There's nothing clear cut.
Gotcha.
Yeah. But, you know, I would just keep isolating and hand hygiene and
Okay.
no visitors.
Yeah. Sounds good. Thanks.
Yeah. Good luck.
So can I ask, maybe I'm going to ask the same question, but I have a non-Syngapian kid who relies pretty heavily on albuterol. Generally speaking, does giving a kid albuterol make them more or less, is it opening their lungs up and making them more susceptible? Is it immunosuppressive? Is it, how do we think about albuterol in the age of pandemic?
I don't know that it has an impact. I mean, I could picture maybe some of the sort of asthma specialists have got a sense of whether or not, you know, albuterol helps or not. But to me, you get exposed, you get infected, and albuterol does not augment that process. it just, you know, maybe helps a person dealing with the wheezing from having those spastic airways from their infection and the bronchitis, but that it changes, you know, the risk of getting infected, I don't believe so.
Cool.
And Mike, did you texted me something? Can you go over what people should expect and how to think about coordinating care with a PCP?
Yeah, just like, it's a little bit like Erica's question, like best practice, just a reminder, best practice is if you really are worried and you're not lucky enough to be in Montreal where you can just drive through and get a test, don't show up at the ER, call your PCP or your neuro, whoever is your primary caregiver, and have them help you fight the good fight with wherever you're going, right? Because we're in an age of ration care, and we're already power users of the health system. So like, from your perspective within the health system, what's the smartest way for us to just approach it in these weird times?
Yeah, I mean, like we've said to folks, if you're safe at home, stay there. You know, plenty of people have gone out and gotten one of these oxygen pulse ox meters for their fingers. I have one with a little polar bear character on it, but it probably needs a new battery. That can help reassure a person. You pop that on and you say, okay, we're 97%, great, I feel better. But really, you know, being able to just look at a kid's respiratory rate. Are they working hard? Are they retracting? You sort of see the muscles working or flaring on the ribs. You know, if they're showing that sign of distress, you gotta go in, right? I mean, that's common sense, hopefully, and you wind up in the ER and they're deciding what they're gonna do to help the kiddo out. Short of that, stay home. I mean, our hospital is not swamped. You know, in New York, obviously, Jess, I can't imagine what it's like right now. I really just can't. I haven't seen video. The one friend in infectious diseases in New York, I just sent him, you know, my best wishes like 10 days ago. But I'm not going to bother a person swamped. But if you can stay home, stay home. If you've got a primary care doctor that, you know, can get stuff done, maybe they've got a process. With Carrie and getting the test last week, they essentially said, if you're going to bring a kid in with a respiratory issue, you're going to sit in your car until we call you. You're going to enter through a special door. You're going to do this, do that, put a mask on, etc. So there is a process to it. And hopefully your primary care can, you know, still provide high quality outpatient care that is safe and, you know, helps your kid without bringing you into the emergency room for just a world of hurt. I mean, I don't like being in an emergency room. Nobody does. But if you have to go, you got to go.
Yeah, one thing they are doing here in New York, this is Jessica, my daughter's 2.5. There's telehealth. So a lot of the primary care physicians offering telehealth to families that are worried or showing some initial symptoms. They can do a webcam, a WebEx or a Zoom, and take a look at your child without having to take them anywhere. So that's another option that you could check and see if your PCP is doing that.
And that's a great point.
I did have one more question. Here in New York, there's a shortage of personal protective equipment, PPE. Are you okay for PPE? Do you need help? Do we need to send anything to you to make sure that Hans is safe? When you go to work every day, do you have everything that you need?
Yeah, I mean, so far so good. Sometimes I have to, you know, ask where it is because we're hiding it. We've had theft from patients and patients' family members. So I think so far so good. I have to admit, I've said to myself, I'm going to see if I can find my old chemistry goggles, because finding the regular masks is easy, but finding the masks that have the plastic shield to prevent droplets hitting your eyes, that's more challenging. So I'm actually going to root around the basement and see what I can come up with, because you know, it's disappointing. It's very disappointing, but we are running low.
Yeah, and I think one of the things that Andrew Cuomo has been saying is he would expect to see a peak like we're seeing in New York in other areas, and I can only imagine that it's going to be the eastern seaboard, New Jersey, and up and down the coast next. So stay safe. get the goggles out.
Yeah, yeah.
So Hans, I have I think a twofold question, and they're very separate branches. So one, kind of piggybacking off of what Jess was saying, you know, one of the concerns in my house is more so if, because my husband and I are the ones who are going out, if we happened to get sick, you know, we've heard wear a mask if you are sick, not to prevent from getting sick. But at the point that we know that we're sick, is it pretty much there's no point? Or should we still wear a mask around the children to make sure that they don't get sick? And then the second part of it is we've seen some reports about chloroquine being used as a potential treatment. And are there any contraindications with seizure medication that you know of?
Oh, that's a great question. So you know, there is that frustrating part to knowing that you're contagious 24 hours before you have any symptoms, right? And if so many people are asymptomatic, I mean, could I have already just, you know, shared it, brought it home and not been ill, or yourself? It's tough. We have a culture that has some degree of expected control. And this is not a circumstance where that's likely. You just can't wear a mask 24/7, even though, you know, they are encouraging that for a lot of people. The second part is, you know, we've had essentially or three groups of medication that we're sort of eager to use, in the sense of the chloroquine derivatives, and hydroxychloroquine is one that we've used in the hospital. Whether or not it works, it doesn't have a randomized controlled trial yet, the way other medications are judged on. And then the second one is the Gilead drug remdesivir, which also doesn't have anything out for its efficacy. And there's other medication that tries to dial down the immune system when ARDS is happening. And those have also just got a smattering of data. With the chloroquine side, it's more of a heart rhythm issue that we keep track of. So what's called a QTC interval on their EKG. Other medications can make them longer. I don't know that Syngap has any predilection to a long QT, and I would say it doesn't, but I don't want to, you know, say 100% sure. There are medications that can prolong a QTC interval, but I don't know the epilepsy drugs well enough to be 100% either. With my little guy, you know, between topiramate and Onfi, I'm not worried. But you sort of have to read the fine print on the specific ones your kiddos are on.
Yeah, I found it interesting when in January Autumn had influenza B, the ER doc who was going to prescribe her Tamiflu didn't really have the knowledge of whether there were any contraindications with her seizure medication. And I consulted drugs.com, and I also messaged her neurologist at that point, who gave me a fairly quick answer. But you know, in that moment, his answer to me was, if you're not sure, don't take it. Like, it didn't feel adequate.
Yeah, that's a person who doesn't want to take the time to go to their reference and do their job, essentially. I mean, I know exactly where to get my drug-drug interaction information from, because you can't memorize that. It's just impossible for me to do. But literally every phone nowadays has got, you know, a medical resource that can do it for you. I hope you guys.
Guys, we're at time. We're over time. So thanks everyone for staying on. I just want to, if people want to keep asking questions, I'm sure Hans will take them, but I just want to thank everybody for joining.
I hope it was helpful.
Absolutely. Yes.
Oh, good.
Yeah, I appreciate you guys doing this.
Thank you.
Guys. Thank you so much, Hans. That was amazing.
Time. Absolutely anytime. You know my email.
Hans at syngapresearchfund.org.
Bye, guys.
Any last questions, or should we cut it here?
Should we post this and then ask any parents if they need any help that we're not available? Even just supports that may be affected somehow, because somebody obviously out there, out of the 500 of us, may have been exposed at some point. We don't know about it yet.
Yeah, I'm sure someone's going to deal with it. So yeah, I mean, the plan was to post the recording of this on our knowledge page.
So Erica, I think to answer your question, one of the things that the patient ambassadors are doing are reaching out to the groups and just making sure that everybody has what they need. I think there is an intention to share this recording, but as far as a personal touch, that is happening to make sure that people have what they need.
And we should get an article out too for people who don't have that time to necessarily listen to the whole webinar.
Yeah, thanks for volunteering. I can't wait to see that. Hans, I do have one question. I sat in on a version of this talk from the Epilepsy Foundation, and they had a neurologist and a pediatric whatever and a pulmonologist, and they were a lot more guarded than you were and basically said, stay home, there's nothing special, be careful. But the pulmonologist said one thing that I hadn't heard before, and I wanted to share it with you with reference to the mention of monitoring your kids' breathing, right? And this pulmonologist was speaking broadly to all the DEEs. So maybe this isn't as specific for Syngap, but he said kids with really low tone, and again, we have a broad phenotypic spectrum, but kids with really low tone may present differently in this regard. Like if they're super low tone, you're not going to see, like my neurotypical kid, when he's struggling breathing, I can see like his fat evaporates and I can see suction on his little lungs. But I would imagine for kids with low tone, maybe it's less obvious that they're in distress. And at that point, should parents just trust their gut, or how to think about that?
I mean, that's a great point. And that's where you're seeing the training and experience of a pulmonologist, who has seen multiple kids in this circumstance, compared to an infectious disease doc with one, right?
Right.
So it's great to hear that. And, ultimately it's a balance between, a lot of times parents feel like I'm looking at my kid and it's not right and I'm not comfortable. And as soon as a person is not comfortable, they're at home, they don't feel safe, whatever the phrase is, it's time to get medical care, because you're out of your limit. And there's no shame in recognizing that you have a limit, or let's say you have an alarm system that triggers at a lower threshold than others. Okay, fine. You shouldn't be abused for bringing your fear for a loved one to medical attention. So, you have to be sort of in tune with what you're comfortable dealing with.
I think the fear and the struggle, and just from personal experience, the one time, thankfully, that Autumn had pneumonia, we had no clue. She had a cold, but we had absolutely no clue that she had pneumonia. It wasn't until she'd been sick for the prescribed amount of time that the pediatrician would look at her, and they weren't even positive listening to her lungs, but they said, just to be sure, we're going to send her for a chest x-ray. So it's hard, as diligent as we are as parents, because of how our children present and how non-responsive they are to the stimuli that happens to their body, it's really challenging to know exactly what's happening with them.
And, you know, did she need to be admitted to a hospital?
No. I mean, she was just prescribed the nebulizer and the antibiotic. So it was early that we caught it, but similarly with strep, there were times where they tested her. We had no clue that she had strep throat and her throat was bleeding, but she didn't give any indication aside from a fever that there was a problem.
I think going back, because Riker has pretty severe respiratory stuff, and he's on the budesonide pretty much daily, and then the albuterol if it's like kind of more of emergency stuff. But even with his extreme low tone, I can still see like his throat go in, you know, his stomach and his chest kind of really trying to work. So for Riker, I could still see those signs. I think it's good. I think Hans said something earlier, having a pulse ox, you know, on hand, even though it's like a battle wrestling a tiger trying to get it on him. But it's, for me, that helps me so I can kind of gauge like where his O2 is at. And now being admitted through the hospital for so many years, I kind of know where his severity is at this point and know if it's ER bound or not for us personally.
So Summer, I think that's a great point. Like, so I have a pulse ox. It's not getting delivered until March 31st now because they keep pushing the delivery out. But Hans, what is an oxygen level that we should be concerned about?
Gosh, you know, I say to myself that if my kid were below a 95, I would probably call, because they're young. They're not supposed to be a 92. They're not supposed to be a 90. They're really supposed to be a 97, a 98, a 99, or 100. And maybe they don't notice a thing, and maybe it's something you just jot down on a notepad, but at least it's a point of information that you can touch base with, whether it's primary care or a PCP about, a pulmonologist about. But I'm not willing to just, you know, for our older patients, as long as they're 92%, we're not cranking up the oxygen. But a kid, you know, and again, I should have a disclaimer that I'm not a pediatrician, but I wouldn't tolerate anything lower than a 95, 94.
This
Yeah,
may
that's
be something with it that Aaron may have to answer as well. This is Erica again. So if they are put on the ventilators, I noticed they said they were sedated. Like with Clara Beth, the last time she was sedated, she coded because her trachea collapses due to the hypotonia. I'm assuming they're intubated at that point. I hope to God we never get to that point, but I'm just curious. It came to mind when they mentioned that. Sorry.
That's all right.
When they mentioned that, that kind of scared me. If she was to be sedated, if she did come down with it, it's. Do you know if, I'm assuming they're intubated? I mean,
I would expect that, you know, they're getting intubated or they are intubated at that point. And what happens is, you know, the trachea comes down and sort of splits, and the tube is just a few centimeters above that fork, that bifurcation. So the trachea should not be able to collapse because the tube is down that far.
okay. Thank you.
Yeah, sure.
Has anybody had that situation where they have had their trachea collapse on a child due to sedation with the hypotonia?
I've not heard of it, but that doesn't mean much.
No, but thank you for the newfound fear.
Ah!
Oh, you're welcome. Yes.
No, Riker's been sedated, and we've never had that issue with Riker on his sedations.
And
Okay. Yeah, we
from
just
my
always
standpoint-
request no sedation.
From
Go
my
ahead.
standpoint, I would think that that's something different than Syngap in the sense of the structure and integrity of the trachea. I would find it difficult to believe that Syngap influences that.
Okay.
All right. Hey,
All right.
everybody. Thanks for this.